jurisdictions where there are, I use the word loosely, proven scientific interventions. And those 6 are tobacco use, high blood pressure, healthcare-associated infections, asthma, unattended pregnancy, and diabetes. And so we're working with both OADP. There is an asthma group within the CDC as well, and they will provide domain expertise too. So a little bit about what we're looking at. So 2 of the initiatives that are used for pediatric asthma are, one is self-management education. So the idea there is that you're matching the child with an educator, and together they build a management plan. And the other is home visits, which is associated with SME, but they also do environmental remediation. So there may be things like filters for vacuum cleaners, covers for pillows, or even more expensive interventions. So the CDC actually doesn't do anything. They make recommendations they work with departments of public health and departments of community health, or 2 of their people that they work with. So even though the CDC is funding this, primarily we're working with Department of Public Health, which I'll say a bit more later. So what our interest in is looking at different states have different, how they pay, if it's fee for service or if it's CMO. There's lots of differences between states. And what they want is a tool to help them to better target these interventions. And also, what is the cost effectiveness of these interventions within this population? So what we've done is we're building a tool. The underlying model is a Markov-based model. Essentially, you can leave a child who's been in 2 states, either have symptoms or they don't have symptoms. If they have symptoms, they may utilize healthcare. It may require an ED visit. They may be admitted to the hospital. There may be an unscheduled visit to their primary care provider. And even when they have symptom-free days, they may also visit, but these tend to be scheduled, and it may be things like medication management updating. And I'm not showing medication costs, but typically you worry about 2 types of medications. You worry about both controller medication and rescue medication. And in particular, you care about the ratio of those. How much rescue compared to controller are they using? And so there's EDIS measures around that. So that's part of the model as well. And the standard measures that states are interested in, they use the word ROI. If you have any accounting, it's not truly ROI. They're really looking at the ratio. It's just cost savings in a sense. They look at what's the benefit of the intervention. So they look at children who didn't receive the intervention. They look at children who did receive the intervention, including the program costs, comparing those costs, and then dividing that by the total program cost. If the ROI is greater than 1, then that would be cost savings. And they're looking for programs that get them an ROI greater than 1 over some time horizon, like 3 years. In addition, there are, and these may include indirect costs, but they're also interested in an incremental cost effectiveness ratio where there may be some specific outcome, like a symptom-free day, and the question is how much would it cost to get an additional symptom-free day for a child? Or how much would it cost, using this intervention, to get an additional school day for a child? And so there you're, again, comparing the intervention and group receiving the intervention and the difference in data effect. And so we're looking at symptom-free days and the school days. So we've essentially built a tool. We try to make this easy, but it's not a sophisticated tool like tools you build at Archie. This is a simple Python model with an Excel interface thing. But we want it easy for states to use. And we're working now with 4 states. We're working with Georgia, Michigan, New York, and Rhode Island. And then there's a total of 12 states that are participating with the CDC that we hope to roll this out as well. And so just a little bit, and then I'll say the Markov model, frankly, was fairly straightforward. But there were some interesting things that we found that I'll say a bit about, after say a little bit more about how it's used. So again, the user can input their unique things about the programs that they have, what are their program costs, if they do an environmental remediation, how are they doing targeting, which I'll say a bit more as well. And then After they input those, then the tool will give them output. So this is a program, for instance, in Michigan, which looked at comparing the group with the interventions with the SME program. And they're getting an ROI of 1.71, which is quite high. Most of them do fall below 1, and I'll explain why in a minute. And then this would say it costs roughly 12 days to get an additional symptom-free day for a child. A lot of research on caregivers have found that the willingness to pay for a symptom-free day is about 20. And so if you can get below 20, that's also a good thing for an ICDR. There's much less work on what is the value of a school day. There are clearly, there's productivity loss, but it's a hard thing to quantify. But we do give that because they ask for it. And one of the things that you need to be careful, what a lot of states do is that they go in, they do their intervention, and then they measure these children over time. One of the problems with that is that you can get the statistical regress to the mean. And what I mean by that is if you have a target, so suppose you're going to target children that had 2 or more ED visits in the past year, and they're going to be your target group for the intervention. Then what can happen is, so I've set this sort of red criteria, and I'm looking at all children that satisfy their criteria. Even without an intervention, if you look at the distribution of ED visits the following year, what happens is you get a regress to the mean. You set a high target. Now if I look at the distribution of those that satisfy the target, the mean is much less than 2 ED visits a year. So it looks like, even without an intervention, that there was a benefit from the intervention. So if you're not using a control, then what happens is it appears that you got a benefit from this program that you really didn't. And so one of the things that we've done, and now this certainly does not replace a control, but we've come up with ways. We have all Medicaid claims data for all the US, for all 50 states for several years. And so we're able to follow children longitudinally and then to come up for the different targeting criteria to then come up with the estimates. Again, I'm going to skip that part, but the estimates for the rest of the mean that we net out then from the program effect. And so just to illustrate this is data from Michigan. So this is 2010, 2011. And suppose, for instance, that you had a target of greater than or equal to 1. I realize this is a lot of numbers. Apologies about that. In these 2 columns. And so what you see is in 2010, you had 10,500 ED visits. If you look at the same group the next year, it dropped to 3,300 ED visits, right? So it looks like there's a tremendous benefit from the intervention, but here these children didn't have an intervention. It's just the regress to the mean effect. So again, without proper controls, we find that many of the states are overestimating the benefit of this program. So the things that we're looking at now is, can we identify good targeting criteria that are less susceptible to this regress to the mean problem? And what we're finding, the nice thing about having claims data is you have addresses tied with that. So we can do very granular measures. And so looking at geography, tying it with certain HEDIS measures, that we can use a set of criteria where actually the regress to the mean isn't much of a big effect. And so that can help certain states. Now this depends on the state, of course. It helps the states to better target then who are the appropriate children that they should apply these programs to. The other thing that we're looking at, let me just go back to this nasty slide with all the numbers, is if you, again, let's look at the same 2 columns. So here there's roughly 8,700 children in 2010 that had 1 or more ED visits. Only 965 of those had a spacer, and only 1,900 of them had flu shots. And so what we're finding is in Georgia, it's much worse. 2% of children are being prescribed spacers. So what a spacer is it's attached to the inhaler, and it allows for better dosing. If you use the inhaler directly, oftentimes the child will cough, doesn't get the proper dosing. So the spacer, you get the proper dosing in here, then they breathe in from the spacer. And so we're trying to look at then what is the impact of prescribing spacers and flu shots. And so again, because we have this nice longitudinal data, then we can do some analysis to try to find those causal relationships. All right, so I'm going to skip gears. Apologize for going quickly here. I was told to do this in about 20 minutes, the research part. One of the other areas that we're looking at is in oral health. And part of it is because oral health is an easy system to describe. It's easy to understand what are the preventive measures in oral health, and it's easy to understand the treatments that are done in oral health. And there's not a lot of comorbidity and complications that one needs to worry about in the area of oral health that if we were looking at cardiovascular disease would be much more difficult. So I'm going to talk briefly about two papers, one that will appear in Health Affairs and one that's currently under review at AJPM. Let me give the people again. So on the Health Affairs paper, we have Susan Griffin, and she is related. She's at the CDC. Christina Scheer, who is at Georgia State, and Shilpa Naval, who's also at the CDC. In the second paper, which is on looking at the value of prevention. This is an important question. A lot of studies recently have found, we all think prevention is good, but in many cases we're finding that actually prevention, many is a strong word. In some cases what we're finding is that prevention is oversold. And so there is an issue about what is the proper prevention. And in oral health, a lot of the guidelines that are established aren't so much evidence-based. And so can you build an evidence base around guidelines? So for instance, if you're going to apply topical fluoride, how often should that be done? And so current says it should be done twice a year, but there's not really any sort of randomized controlled trials that have been done to say why it should be 2 times a year. Okay? So the second paper, Nicoletta Serban, who is a statistician, she's in the same department as me in ISYE. Scott Tomar, who's on the dental school faculty at University of Florida. And then Sean Monahan, who's an undergrad, and Ilbin Lee, who's a postdoc, also in ISYE. So let me say a little bit about what we're looking at here, and I'm going to reverse the order, and I'm going to go quickly here. Particularly the second paper is technical, so if you are interested, again, I'm happy to email that to you, but I'm going to just present the results. Okay? So essentially, so why do we care about oral health first? So actually, oral health is the most prevalent unmet need amongst children. And there's huge disparities in oral health as well. And a lot of it is due to access issues that I'll talk about later. And so for instance, if you look at Pitt and Fisher sealants, they're known to be effective. Whether they're cost savings or not is another, but they're known to be cost effective. And yet, less than 9% of low-income children received at least one of these services in 2009. And so there are things that so tooth decay is completely preventable, right? And things that we know tend to work well are only being received by a small subset of the population. This is why we care about the problem. Okay. So we looked at, so what we want to do is, what is the value? We're looking at 2 preventive services. Topical fluoride, which is essentially painted on the tooth, and sealants. And I'll show you a picture of the sealant in a minute. And those are painted into the Pitt and Fisher of molars. And so we followed roughly 1 million Medicaid children over 7 years. And so we're looking at them at 3 to 6. And the reason is because sealants tend to be applied at 7 years old. It's when the molars are ruptured. So 7 and 8 is the time that the first molars at least were sealed. And so then we followed them over 7 years. And we also did some segmenting. We looked at, quote, healthy children based on the clinical risk grouping. And we looked at all dental-related claims. And so what we did is we looked at then the utilization over the 7 years. And a child had to be enrolled for 5 of 7 years in Medicaid to be eligible in the study. So we looked at their utilization of preventive and restorative services over the 7-year period. And then we described that as a Markov renewal process, which we then used some machine learning to do clustering to sort of define 4 groups. And the 4 groups are, prior to a restorative care, they received neither TFL is topical fluoride, SEA is Pitt and Fisher sealant. They receive sealant only, they receive topical fluoride only, and they receive both. And then so what we're interested in is, so what was the impact of that? And so I'm going to cut to the chase and just show what the results are in terms of money. So I'll just show you for 2 states. So for Georgia, so these are the 4 groups across the top, and the percentage that fell into the 4 groups initially. And so what you see then is, so what is the corresponding cost? And we're measuring cost and expenditure per child per year. And so if they receive neither fluoride or sealant, then it was roughly $209 per child. If they receive sealant only, that cost dropped to $96 per child. So that includes all costs. So it is cost savings, is what that means. Fluoride also is cost savings. It's not as cost savings as sealants alone, but then the combination is even more cost savings than just sealants. Now, again, there are big differences, reimbursement rates and so on between states, and so I'm showing Texas as well. And so again, all of the 3 interventions are cost savings. But you see the dollar amounts can be quite different. So there are state effects which are interesting that I'm not going to go into now. But so what does this mean from sort of a Medicaid perspective? So if you looked over 7 years, a child who had regular topical fluoride would roughly spend $518 less than a child who hadn't. And that includes all costs of applying the topical fluoride. And if they have fluoride or sealants, then that would be $812 less per child. So if you think about that from the state perspective, so if Georgia, for instance, and these numbers would be, well, I do get Texas as well, if they were able to provide those services to roughly 20% of, and very few of them are getting them now, as you saw from the percentages, to the children who aren't getting even 20% of those, they would save roughly $7 million a year, just the Medicaid part for Georgia. And for Texas, it would be roughly $26 million a year. And for Texas, they would avert roughly 70,000 caries or cavities a year. And for Georgia, they would avert roughly 21,000 cavities per year. So why aren't states doing this? So one of the problems is this issue of access. So this shows, so here I'm just focusing Georgia. And what this shows is, it's hard to see the white spots. And I'm not going to go into details about what served and underserved means. Essentially, it means you're within 50 miles of a provider. There's dentists, whether you're in a county that's a person defines as a DIP. So there's several things that define that, right? So most of Georgia is underserved or unserved. And so, in fact, in 54 counties in Georgia, demand for oral health was twice supply. And if you look at children on Medicaid, they travel on average 20 miles greater than their privately insured counterparts. So it's an issue. So how do we provide this care to children that are on Medicaid? And part of it, only 33% of dentists in Georgia will accept Medicaid patients as well. So this is another issue. So what are strategies that could help to improve access? Well, one is we could target those services to at-risk children, things like school-based sealant programs. So there, you're using portable chairs, you're going into a school, and you're applying sealants. You could use other people than dentists, like pediatricians, to apply topical fluoride. And a big deal is practice acts. So what that means is, in many states, and Georgia's one of those, a hygienist would not be allowed to apply a sealant unless they were under direct supervision of a dentist. And they certainly can't bill for applying a sealant. And so what would happen, and some states have relaxed that, so what would happen if you relaxed those practice acts? And so I'm going to look specifically at the school-based sealant program in just 2 slides. So again, this is a picture of a school-based sealant program with the portable chairs that are going in. This is what a sealant looks like applied to a tooth. And so what we did is that, and this is CDC data, they got data from 13 school-based, from school-based sealant programs from 14 states. And we were interested not just in cost, but also we're interested in a qualitative measure, and we use disability-adjusted life years. WHO recently came out with a DALY for tooth pain. So we had to build a model, of course, for the progression of decay and the likelihood of tooth pain. I'm skipping all of that. But we modeled programs, and we limited our analysis to 4 years. All costs are in 2014 dollars, and then we discounted both cost and health at 3%, which is sort of standard practice. So what we found is that without school sealant programs, many low-income children would not receive sealants. It's the primary way that they get the sealants. Providing sealants to 1,000 children would avert 520 fillings and save 2 disability-adjusted life years. And that there are cost savings over a wide range of parameters. And not many things are cost savings. There are a lot of things that are cost effective, but not a lot that are cost savings. And so, well, I screwed up the slide here, but here's sort of the range over which, if you look at attack rate, is essentially the likelihood that a tooth gets a cavity over a year. Program cost, you see over a significant range is cost savings. And if you use GDP as the cut point, which is roughly $54,000 the per person, it's roughly $54,000, then you see that much of the rest would fall under what would be considered the cost effectiveness range. Now, of course, there's barriers. As I mentioned, there are dental practice acts, and labor accounts for roughly 2/3 of the cost in school-based sealant programs. But you can't simply let hygienists loose. A hygienist can't just show up at a school and say, "I'm here to seal your child." There has to be coordination with both, for it to be successful, with the Department of Education and the Department of Public Health to get that access into the schools. And one of the barriers is, frankly, equipment. It costs roughly $20,000 for a portable unit. And so it may require things like equipment loan programs. And we are looking at modeling the effectiveness of that as well. And consent is another issue. Currently, so what has to happen is they tend to go into the school the day before. Those children that have to take a form to their parent, their parent or caregiver would sign, and they're only getting about a 50% return on consent forms. So there's a lot of things that can be done to improve consent as well. Okay, very quickly, let me just mention again, just because I'm in the state of Indiana, and we're very early in this. This is with the Centers for Disease Control. This is Yashuan Chen. She's the one who actually led the contact tracing effort in Scott County, so she's with the CDC. Everybody else are really smart undergrads. So we have Anmol, Henry, Catherine, David, Saeed, and Bonnie. And we're working on, which I'll talk about here in a minute. So as you know, living in the state of Indiana, Scott County was declared essentially an emergency because of the spread of HIV, primarily through injection drug users. And just to give you a couple of statistics, I think you all know enough about HIV. Let me just mention in Scott County, roughly 194 out of 4,200 people became infected. And what the CDC is concerned about is that, of course, there are many other counties that have similar characteristics to Scott County, particularly around injection drug use. And this tends to not be heroin. This tends to be crushed up opioids, which requires a bigger needle to inject. And so they're concerned about this being repeated in other places. Now, contact tracing takes a really long time to go in, and it takes literally months in order to do that. And so what they were interested in, and I'm not saying that the CDC doesn't have modelers, they definitely have lots of HIV modelers, but what they were interested in is for us to help to build a tool. Again, it's a network-based model where they can look at the impact of interventions that I'll talk about in a minute, that they can use with state departments. So again, the CDC can't make a state do anything, but they could provide advice, and what they're hoping is they'd like a tool where the state could see what would the impact if we use these interventions. Again, we have data from Scott County, as well as there's a lot from the literature modeling this in EPI model. We're using random exponentially ERGM model in R. And so essentially what happens in the network, you're considering the nodes as people. And we're modeling this compartment model where there's actually, they can either be susceptible, but we care about whether they're acute or chronic because the infectivity of the individual is different for people in the acute and the chronic state, and we want to be able to model that. And then we're looking at relationships where they either share a syringe or there's a sexual relationship between parties. And so then the question would be, given initial seeding, how would one expect that network to grow? And then what that allows you to do is, how can I then target interventions to stop the growth? And we're looking at two things. We're looking at needle exchange, or it's actually, I can't say the word syringe exchange program, as well as PrEP. Where PrEP, you're essentially, that's individual based, you're giving somebody antiretrovirals as a preventative measure to get HIV. And so this data is meaningless, just gives you an idea of the tool. So what we can do is look at the intervention change, how it's used, and we can plot out sort of how things would change over time, as well as how the network evolves over time. Again, we're early in this, but it's kind of fun work. I don't want you to think that I only do work in public health. I do work with hospitals as well. I have a project with the military health system where we're looking at the patients that are in medical home. And I'm doing work with Geisinger where we're looking at work around sepsis. We're doing, everybody of course has a predictive model on sepsis. We're doing that as well. But we're also trying to look at, can we think about sepsis from a systems view? So it's not just, am I predicting that somebody coming in the hospital has sepsis or septic shock, but can I look at sort of where they present from, their transitions of care, sort of use those systems measure where I can then make some change to the process itself. And so a combination of those things. All right. So my future of healthcare delivery. Now, I'm not a doctor. I'm not an economist. I'm not a policy person. So I'm leaving out a ton here. I'm not talking about new drugs or new delivery. What I'm going to focus on are those things that I think are important from a systems view. So I'll start from the data. Of course, we have to start with the EHR, and I'll say a few things about these. And of course, I'll be saying things that I'm not an expert at all about. But what I at least, I'm giving it my best shot here. So I'm going to start from data, and then how that is sort of used through the system all the way up to healthcare financing, which I think is the hardest thing to talk about predicting for the future. I will remind you of a famous quote from the great Yogi Berra, who says it's tough to make predictions, especially about the future. So please keep that in mind. All right, so let me start with of course, you're all familiar with the electronic health record. There's been massive investments in EHR. They've been incentivized through programs like Meaningful Use, and there's been huge benefits from the advancement in EHR. There's better data access. There's lots of computerized physician order entry. There's lots of benefits from the EHR. But it is still the case that EHR systems are fragmented. It's often the case data is not easily shared. And there's frankly a lot of EHR errors that result from the use of the EHR. Bill Rouse, who in fact used to be at Georgia Tech and at Stevens, made the point, and I agree with this, that if you look at IT and healthcare, it seems to be about 15 years behind IT and manufacturing. So I'm optimistic that these things will be fixed, but they're definitely fixed. And just to say a little bit about some of the reasons. Of course, there are technical variations. There's lots of vendors. There's hundreds of EHR products, and so that's a challenge. There's the economics. Who's going to pay for certain things? And so there is a lack of incentives to develop interoperable systems. There can be high data exchange fees. So if I'm plugged in, if I'm a small delivery site and I want to plug into someplace else, I may have to pay in order to get that information exchange, and sometimes it can be quite high. And there can be usability issues. One of the interesting things I saw is one of the biggest problems is the copy and paste function. That leads to many errors by physicians in using EHR. This is how HIMSS defines interoperability, and they say there's really three components. There's foundational, structural, and semantic. You can, data is safe and secure and be transmitted that way, that you can do analysis and share between physicians. And then this last one, the semantic, is that we can draw insights from analyzing data. Now, not everybody would define interoperability. This is a pretty broad view of interoperability, but I'm going to use this as the basis. And on the first two, there's been really great progress. I think a lot of people are excited about FHIR. So FHIR is the Fast Healthcare Interoperability Resources. And what FHIR essentially does is it builds a profile for an EHR and allows for plug-in to a common API. And the benefit about that is not only does it allow for sort of this plug and play, but it essentially opens up a whole market, because it's through this API, for services to be provided on EHR. So you have all of these things like Smart on FHIR, X on FHIR kind of things that are being developed that people are making money from, right? But it's still the case that on the semantic side, there's huge amounts of opportunities. Now, a lot of people are doing research in this. You guys are doing research on this. We're doing research on this. But essentially, there's a lot in predictive analytics. Readmits, length of stay, all of those things. But then the question is, what does that really mean? How do I make a decision on my predictions? And so the whole issue is, what do I actually do with these? And so there's a lot of opportunities about what really is the evidence, right, that we can state that we're able to pull from this data. How do we tie to process? And EHR is getting better at this, but it tends to not contain a lot of process data. I'll explain what I mean by that in just a minute. And the other thing is you need to inform and integrate this with, of course, the people who are using it. And so there's the whole usability issue is still sort of wide open in this regard. Do I need to go through lots of screens? Are things being brought top of mind? And so there's a lot of opportunities. So just one silly little example of how this, this kind of process. So one of the things, at least we found with Geisinger, this is not a Geisinger ICU, this is just a generic ICU, one ward, is that patient outcomes were differing by ward in the ICU wards. And what they found is that the staff was being essentially overloaded in different, some of the staff is being overloaded, some of the ICUs, in terms of how they schedule patients to wards. And so wards where the staff were more overworked, patients had poor outcomes. And so you can imagine then having a system where you predict length of stay, a person when they come in or they can be admitted, the workload that's going to be required for this type of individual, and actually schedule them in a way that balances workload across to help to improve patient outcomes. Related to process is sort of built environment data as well. So it's possible that if we look at this ICU, the nursing station sort of is facing forward. I'm back behind here, my visibility is worse. And what some people have found is sometimes when you have poor visibility, you actually get poor sort of death rooms in the sense that they're not as top in, that's a strong word, I realize. When you want to publish a paper, use really strong words like death rooms. But at least outcomes have been found to be worse that are related to visibility issues. But I think that whole area of how built environment relates to process is really in this. Related to this, of course, is how we move the point of care. So this is a physician we work with, Kevin Mayer. He's a pediatric cardiologist. He's head of cardio nanomedicine at Emory. And he said something to me. He said, when I see a patient, I'm lucky if I see them twice a year. I get about a 15-second signal, and then I determine their care for the next 6 months on that 15-second signal. Right? And so what if there was a way that we could, and of course a lot of people, including Purdue's doing a lot of great work in this, what if we could better integrate into and provide for him additional information that he's not listening to a heart for 15 seconds and then determine the care process for the child. And so, so clearly telehealth is a hugely expanding area. And roughly 6% of professionals say they're already using it or will use it within the next couple of years. And traditional telehealth looks just like this picture. You have a physician on one end, you have a patient on the other end, and they essentially are talking. There may be measurements that are done. So you see somebody there that's measuring blood pressure and so on. And this is the only way that Medicare will fund telehealth. Unless there's a face-to-face meeting between a physician and patient, you can't bill for it. And there's all of these other opportunities to use telehealth that isn't a direct face-to-face meeting. So let me just say a little bit about this. So again, the benefits are you have less patients in waiting rooms and more flexibility. It can really help with noncompliance because it's easier to do follow-ups than somebody coming into a clinic, for instance. There's very low setup and overhead costs. You have the potential here to reach underserved populations. It's not happening yet. It's still the young and affluent that are primarily users of telehealth. But there is an opportunity for that to happen. And it's expanding tremendously. So we could also go beyond the notion of telehealth. So you could think of how devices may integrate. So if I go back to asthma, here you see a woman with a device that can measure her lung capacity. You might even be able to build that into the nebulizer. And so what you could think about, so now the woman became a little girl with a soccer ball, then the girl has a mobile device inhaler that's uploaded. There's lung capacity measures. That can help to update what should the dosing be for the child. Of course, that can tie in with health analytics to what are other similar children, and can we use information about them to help make the decision about dosing requirements, not just based on the history of that one child. We can still have the traditional view of telehealth. We can do things like remind the child of a flu shot. She may have questions to an asthma educator. There may be a support group. There's lots of ways that this, of course, can be used. But the fundamental problem is somebody has to pay for this, right? There has to be a reimbursement model for this to happen. And that's, frankly, been a big challenge with a lot of the implementation of medical devices. So the challenges also in that scenario, of course, is big data quality and security issues. So how do you know you're getting good signals? What do you do if you believe that you're getting noisy signals? Reimbursement, as I mentioned, is a problem. How you integrate that related to the healthcare system, it's not like a Fitbit that you have, that this information is going into EHR and be used. And as I mentioned, the traditional use is primarily by the young and affluent, and even for Medicare, it's primarily for people under 65 and primarily around mental health. So there's huge opportunities still. I'm a believer in this technology. But really the issue from an engineering perspective is how do we target those services? What are the right services to provide through telehealth or through medical devices? And how do we target those? So there's a lot of opportunity around that. I'll try to finish up quickly here. Obviously, personalized medicine is a big deal. This is one of my favorite pictures. This came from Nature last year. These are the top 10 highest grossing drugs in the US. And so if you look at, say, Crestor, which is right here, the blue person means that there was a clinical effect from the prescription of Crestor. The red means there was no clinical effect from the prescription. And so you see there's very little clinical effect in the prescription of the top 10 grossing drugs in the US. Now, there are a lot of reasons for that. There may be an economic incentive, but the authors of this article, their point was it's a fundamental flaw of RCTs. Essentially, they're biased, and so I'm a 55-year-old white male, and how a drug may maybe have stomach cancer and maybe how a cocktail impacts me compared to, say, a 35-year-old Asian female. So how do we think about our sort of personal unique characteristics in terms of medicine? So of course, the whole field of genomics has taken off, and there's lots of opportunities in genomics with big data and analytics. And there's still a whole business model issue. genome sequencing has come way down in price, but when does it really make sense to use? So there's sort of all of that, and analytics can also play a role. Again, it's simply, it helps to identify risk. That's not certainty, it's a risk, right? And so there's other information that can be used. And I'm probably butchering an actual word, but so I use the word exomics. So if we think about our genetics, but we also think about our environment, there are also personalized components of our environment as well that I believe can also be incorporated in this whole issue of personalized medicine. Just a couple more slides. Care coordination is another area, of course, that she uses as the art definition. It's an essential part of the patient-centered medical home, and in part driven by this notion of the triple aim. Now, there's challenges in care coordination. One is people don't like to talk about costs. Right? But if you're really going to do care coordination, it's not only important to understand. So I'm not going to read this. I'll summarize in 2 lines. This is something I stole from New England Journal of Medicine that I like. So someone with stomach cancer, there may be a drug that they can take that will extend their life for 5 months. And it may cost them $50,000, and maybe they're out of pocket, or sorry, $44,000, and maybe their out of pocket is $8,000 to $10,000. And maybe it increases their risk of a heart condition by 2%. With probably one, the physician will talk to the patient about the 2% increase in risk. But it's unlikely that the physician is going to talk to the patient about what is the financial impact of the decision that you're about to make. And with care coordination, that whole area needs to be figured out. How do we think about the cost? There are lots of other things. There are lots of things in the PCMH. For instance, one of the things PCMH does is it reserves a large number of capacity for walk-ins. I want to have the ability to do immediate care. It's unclear what that really is in terms of outcomes. Is that a good idea or not? And so I think there's a whole lot of things about, we have good ideas, but can we really link them to outcomes is really important. Team coordination is also important, particularly when you're looking at patients with complex conditions. And there's a lot of people that are looking at not just coordinating care within the clinic. How do I coordinate care? Marianne and I were having this discussion last night, and she made the point that if you look at healthcare costs, you sort of slice out 10% of it is really treating conditions, right? So you have all of this other stuff that impacts health. Can I get housing? Can I get food? So a lot of organizations are really looking at how can I connect a person just gets out of jail or a person moves to a new community. How can I connect them to all of these resources that have an impact on their health and wellness? And so this is, we're doing some work with United Healthcare on this issue with the food bank. And then of course the very last one is health grant financing. We all know that it's very expensive, and there's been lots of changes recently. CEOs care a lot about financing. Most small hospitals lost money last year, and so there's a lot of concerns about financing. So, and fundamentally part of the reason is that we have all of these agency issues that are a result of, we have a patient, we have a provider, we have a payer, and the incentives aren't always aligned. And we have a government that sometimes is a payer, but is also a regulator. And so because of this system, there's all kinds of agency issues that also complicate the whole financing issue. So what can we do to bend the curve? There are a lot, I don't know. Right? And so part of it, this is really a political issue as well about where are we going to be next year with healthcare or healthcare reform. But there's clearly a lot of things that people are looking at. What's the value pay for performance, or shared savings plans, or how about employee wellness programs from employers? What is their impact? Or trying to provide additional information to consumers so they make better choices, so that there's a market effect. So there's a lot of things. What I do know is there's going to be a lot of interesting problems for forever in this particular, even if we go to a single payer system where there is no market, now maybe it becomes even more important for engineering and economics and finance to think about that particular system. So maybe I'll end on a goal. And so for me, I hope this isn't too flowery, that if we can move from this interventionist mindset to one that embraces proactive action and appropriate prevention, not just prevention, as well as embraces an inclusive team-based communications. And what that means is systems thinking is first and foremost in this, that we do leverage all of the things that we can integrate across services and providers, that we do think about individual issues, and that we care about the health of everybody, not just a select few. So that's what I got. Any questions? So the question is, how do you care about so many children that aren't getting access aren't on Medicaid. And there's really two types. They may be completely uninsured. Maybe their parents didn't enroll. They qualify for Medicaid, but they didn't enroll. And so what school-based CLENT programs tend to do is you look at schools, you can use a measure like free and reduced lunch percentage, but free and reduced lunch meal program, and look at the percentage of children that are on that and sort of target based on that. Now, you have to seal everybody when you go into a school, and so you are getting across the whole spectrum, including people that may have insurance, and you can bill for that. But this is an issue. There are people that don't, frankly, have financial access to oral health care, and that's an important component of the population as well. So what does that even mean? How do you find those is an interesting question. And then how do you address for the children or adults? I talked about children, but honestly, the biggest problem in dental care are working adults. If you look at, things have improved somewhat for children, but things have gotten much worse for working adults, actually. There's no coverage for adults. Medicare doesn't cover oral health, and Medicaid, there's only a limited number of adults that are covered by that, so it's all out of pocket. Yeah.
You know, we work with Medicaid and Medicare providers throughout the state, and our biggest concern is when we work with providers, the evidence for the policymakers may be clear, but to your point of alignment, the evidence to a practitioner is not clear at all. And not just from the medical evidence, but from the business case of the evidence. So why should I do medical home again? How does that help my practice be better? And you can tell me about penalties and suffering in the future, but I live in the present, I work too hard. And so I don't know if you have thoughts on, that's our biggest challenge is making the case to the provider that it's going to help them now.
Yeah, so the question is that there are Medicaid policies, but where the provider actually convinced that they make sense for her or him to actually implement is a challenge. And that's a complicated thing. I mean, you know, the reimbursement rates are far below for Medicaid, are far below private rates. So if I'm in a community where I'm getting enough demand from the private insurance market, why am I even going to see Medicaid children?
Or why should I worry about sealants
Right.
when I don't get paid well enough to wait? So you're asking me to do one more thing
Yes.
that I get helps the patient,
Yeah.
but I'm already overburdened, my schedule's too busy, I don't have enough time to think my patients to begin with, and now you just told me to do one more thing.
Yeah, and so then the follow-up is that there are these unfunded mandates, right, if you allow me to use that word. And so what I would argue is that's why I think looking at who provides the service is worthwhile. I think the ADA has been nervous about relaxing practice acts because they're concerned about what demand for their services will be over the future. And so really I think that's the battle to fight. I think that adding more things to a dental, that's not how CLENTs, and you're not really targeting the children who need them anyway because they live so far. And so if you can find alternative mechanisms, I believe that's where you'll have the most success. The key then is how do you convince the state that it's in their interest then? And so we can match them up with Highmark, for instance, to look at, here's all the data for their pay for performance. Can you try to model this from an incentive or an agency framework? So I think one is identifying what are the cool problems that faculty would want to do that match their skills. And then tying them to the things that is really hard for an individual faculty member to get. And then if you can leverage, if you have resources, which seems here at Purdue, you guys are swimming in resources. I need to send our president up here to visit. And so, what I like is that your centers actually have resources. and so then it's an issue of trying to identify, there are things like seed grants to try to bring, but, it's hard, if I want to write an ERC proposal, that's completely out of my line, right? I'm spending months, and if there can be resources that can help me with the writing, all of that stuff becomes easier. And so, but I think, part of it is first getting, which I think Mary Ed has done a great job in getting the community of faculty together to identify what are our interests, what are the things that we bring to the table, and then how can we identify, you can't do everything, but can we identify a few key things that it makes sense as faculty either to start initial work and then maybe to go after larger funding. So, yeah.
For the future of healthcare, in terms of data, you mentioned about interoperability between EHRs. What are your thoughts in terms of integrating other sources of data like medical device, genomics, imaging? And
so
what's the benefit and where are we going in terms of that?
Yeah, so the question is sort of what goes beyond the EHR, what data is important. And I think all of that, unless it's fundamentally integrated with the EHR, it's independent of the system. And there may be interesting research, but it's not going to change healthcare. And so I think that if you're in devices or there are genomics, there has to be a way to connect that then to the health record, that these types of things, whether it's looking at process or whether it's looking at personalization, can actually be done. But there are literally thousands and thousands of people that are working on this model. So as I said, I'm actually optimistic about that aspect.